Hi, hi, everybody.
Hello, everyone. Thanks for joining us. Just give a minute and then we'll start. Hi, Jack. Hi, Pravish.
Hi. Good evening.
Hello. I think it's 8 o'clock in the UK and 9 in the Netherlands and Europe, so we can start, Mohammed.
Yeah, okay. So, hello, everyone. My name is Mohammed Abulazaim. I'm a surgical trainee in London, UK, and I'll be co-moderating this TUGS lounge session with my good friend and colleague, Jack, from the Netherlands.
Yes.
Jack is an ICU resident in Netherlands, and of course, he's a TUGS Scientific Sunday coordinator. And as you know, TUGS Lounge has been a successful event over the last 8 months, discussing different topics important to all the clinicians and surgeons. So firstly, I ask you all to, if you can keep your mic muted at all times, but please do engage and ask questions. And so you can use the chat box to ask questions, and we will discuss it in the Q&A session, or raise your hand during the Q&A session and we can discuss the questions. Our topic today is one that we face every day in surgery, and actually it's crucial to the patient's journey. We will be discussing nutritional challenges in surgery and in the ICU. We have an expert panel members and speakers today, and I thank them all for joining us. And the first on our panel members is Professor Vishwanath. Professor Vish is an upper GI surgery consultant at James Cook University Hospital in UK, and he currently serves in the ALS-GBI Council and the ASGBI Endoscopy Committee, and he's also Program Director of Postdoctoral MCH at Teesside University. He's also a reviewer and editorial board member of various surgical journals. And we have the rest of the expert panel, and I'll leave my good friend Jack over to you, Jack, to introduce the rest of the team from Netherlands.
Yeah, thank you very much, Mohammed. This is an overall Dutch session, which is of course very lovely. Our second panel member is my good friend and colleague, Dr. Ramnarijn. Darmanath, welcome. Darmanath is attending internist and intensivist at Elisabeth II Steden Hospital in Tilburg, the Netherlands. And on a daily basis, we work together. His main research interests are nutrition in critically ill patients, of course, and secondly, the post-intensive care syndrome, in which he's performing a PhD at the moment. That's one Dutch friend of mine. The other Dutch friend is currently in the OR, and hopefully he will join us soon. That's Dr. Michel Leijer. He's not there yet, but he's an upper gastrointestinal surgeon in the Catharina Hospital in Eindhoven, the Netherlands. Just to be honest, a surgical nutrition guru over here and in the rest of the world. He's famous for his nutritional trials in surgery, especially the Nutrient trial and the Sanex 1 and 2 trial. And both of them have been published in very high impact journals, and you probably have heard of it. And if you didn't, after the session, I'll invite you to look them up and read them because they're very interesting. That's for our panel members. As Mohammed said, we have two speakers. One. As Mohammed said, we have two speakers for this session. I'm proud to introduce the first one. That's Monica van Nieuwkoop. She did her research internship as a part of her training to be a nutritionist in our ICU department. And she studied the overall prevalence and risk factors of enteral nutrition interruptions of patients in the intensive care unit. And she's going to present her findings. Monica, welcome, first of all, and good luck. The floor is yours.
Thank you, Dr. Pauwels, for the invitation. It's my pleasure to be here. First, I want to introduce myself. You all already have heard, I'm Monica van Nieuwkoop. I'm working as a dietitian in the Netherlands. And last year I did research about enteral nutrition interruptions in the intensive care units in the ICU in Tilburg. I will give you an overview of this presentation. I will say something about the background, then I will tell you something about the research questions. We will go to the methods. I will share my findings with you, the discussion. I will conclude, and then I will give my recommendations as well. And after this presentation, you can ask me some questions. The background, I will start up with the definition of enteral nutrition that we used during the study. Now, enteral nutrition is a liquid that contains of nutrients which are administered through a flexible plastic tube directly into the stomach or intestine. Now, we all know that adequate nutrition is essential for the recovery of critical ill patients, but there are several studies have shown that patients of the ICU only receive around 60% of their target nutritional intake. A common reason for this inadequate intake of calories and proteins by critical ill patients is an enteral nutrition interruption, an ENI. From now on, most of the time I will say ENI, it's easier for you and me. Now, imagine that you skipped one of your main meals. It's possible that you don't feel it, but when a critical ill patient eats, he or she can lose a huge amount of muscle mass. So they can lose up to 1 kilograms muscle mass a day for the first 10 days. So this is very high. An inadequate intake can also lead to malnutrition. Now, malnutrition increases the risk of complications such as infections, pressure ulcers, and delayed wound healing, and a longer stay in hospitals. And this causes in a higher healthcare cost and a higher mortality. Now, worldwide, there are a lot of studies available about the frequencies, durations, and causes of these interruptions over the last 20 years. And one of these studies was conducted in the ICU, and the study was published in March 2005. This case study has only patients who get enteral nutrition for at least 48 hours during the admission. And in 1 year, 403 patients were part of the study. And from those patients were 3,526 dietary days recorded. So the study shows that patients achieved their nutritional goals in only 52% of the days. So it's very low. Now, there's also a systematic review published in July 2018, so 3 years ago. And they collected study data from 3,390 patients from 26 countries. And this systematic review showed that they got only 61.2% of their energy requirements and 57.6% of their protein requirements. So other studies also vary in causes, frequencies, and duration of the INE. And it's because of the diversity of the hospitals in different countries worldwide. So this research is valuable because there is no recent study conducted in the ICU in the Netherlands. So the research questions, I designed the following questions to discover the answer to the question in what severity INE is a problem in the hospitals in the Netherlands. The main question is, what are the causes, frequencies, and duration of enteral nutrition interruptions in relation to malnutrition by ICU patients during the first 7 days of admission in the Elisabeth II Stede Hospital? Now, I split it up in 4 sub-questions. The first how many ICU patients get interruption of enteral nutrition during the first 7 days of admission. The second is how often are interruptions measured of enteral nutrition in the ICU patient during the first 7 days of admission. The third one, what are the causes of INEs in the ICU patients? And for what are the percentage of ICU patients, what percentage of ICU patients have an adequate caloric intake during the first 7 days of admission. We go to the methods. Now, this was an observational prospective cohort study conducted in the Elisabeth Stede Hospital in Tilburg, in the Netherlands. I just said it. Now, our intensive care units consist of 4 separate units, and that's the total 34 beds. The study includes medical and surgical patients. Think about neurochirurgy, traumatology, and others. Now, the study inclusion period was from the 26th of April until the 4th of June in 2021, so last year. As you can see in figure 1, the following inclusion criteria were defined. The first is the admission to the ICU. Secondly, started receiving enteral nutrition within 48 hours. And third, staying longer than 48 hours in the ICU. Now, patients were excluded when they cut partial oral food intake, full oral food intake, or total parenteral nutrition. Now, as you can see, data is collected from the first entire day until the day the patients start to resume oral diet, discharged or deceased. And the results of the patients are collected for a maximum of 7 days. Now, as you can see in figure 2, there is information collected that provides insight into the causes, frequencies, and the duration of the interruptions. I will explain some of them. The short nutritional assessment questionnaire score, that's a score we use in the Netherlands for patients. Then we can see how what the risk of malnutrition is. And we calculate the energy and protein targets, and that is we use the Aspen guideline. I think also other countries use them, but I will later in this presentation explain that. I'm sorry, I will say something about that. I forgot. The Aspen guideline says that you have an adequate food intake when you get between 80 and 110% of your nutritional intake. The targets. The results, that was collected from 165 patients. You can see 104 patients are excluded of the study, and this has 2 reasons. 77 patients had no enteral feeding within 48 hours, and the other 27 patients were not longer in the ICU than 48 hours. Now, we included 61 patients. The results, I will give you an overview of the patients who included in the study. You can see the mean age was 60.8 years with a standard deviation of 14.3. The gender, you can see that the more patients were male. The BMI, nice to know, is 29.4 with a standard deviation of 4.9. You can see at the category of admission that pulmonology is very high, 26 patients. And you also can see that the days of the ventilation, mechanical ventilation, is almost 90%. And you also can see that almost half of the patients get prokinetics. So question 1, How many ICU patients get an interruption of enteral nutrition during the first 7 days? Now, you can see it in table 2. In the first 4 days, you can see that about 20% of the patients got 1 or more enteral nutrition interruptions, the ENAs. And you can see that it's decreased every day. So in day 1, almost 40% get an interruption. Day 2, 33%. And day 3, 28%. So it decreased every day. And you also can see the duration of the INEs in hours. So day 1 was 11.9 on average, on 11.9 hours with a standard deviation of 9.5. And you also can see that on day 1, 2 patients get more than 1 INEs a day. And in the last, you can see 22 patients on the day A1, 1 INE. So sub-question 2. Now, how often are the interruptions measured of enteral nutrition in the ICU patients during the first 7 days? In total, 150 INEs were measured. And the most interruptions occurred during the first 3 days of admission. So you can see day 1 is 26 INEs, day 2, 28, day 3, 20, and the other days is below the 20. Sub-question 3, what are the causes of enteral nutrition interruptions in the ICU? I split it up in table 4A and 4B. You can see it. I split it up in interventional and diagnostic factors and in patient-related factors. The common reasons for INEs was a CT scan. You can see 27 INEs. That's the most. You also can see that intubation, extubation, and the surgery is high compared to the others. And then you can see high gastric residual volume is after the CT scan at highest. And dysfunction from the tube. Now that are the causes. And then the importance question, what percentage of ICU patients have an adequate caloric intake during the first 7 days? Now, as you can see, more than 70% got an adequate intake, and they based on the ESPEN guideline. As I said, patients had an adequate food intake when they got between 80 and 110% of their nutritional targets. Now, more than 70% had an adequate intake, but almost 25 patients had an inadequate food intake in the first days. And here you can see the green bars of patients with an adequate intake and the gray bars with an inadequate intake. And on the fourth, we find some significant information. In the first 4 days, it was seen that a significant difference between the average percentage school feeding reaching the INE group and the non-INE group. Now, the discussion. I compared our study with the other studies and come to some remarkable points. The first is that several studies use different methods to calculate the energy target intake. So we calculate the energy targets based on the ESPEN guideline. Other studies use different formulas related to age and gender. And there also are studies who used 25 or 30 kilograms in weight. So secondly, studies have different definitions for an adequate food intake. As I said, we use the ESMA guidelines, so we use 80 to 110% of the nutritional targets. Others say that a minimum of 90% is an adequate intake, and there are also studies who get 100% as an adequate intake. The third, studies use different definitions for an interruption. Some studies speak of an interruption by a minimum of 15 minutes, and others speak of a minimum of 1 hour by INE. Now, we collected all the interruptions. For kinetics can affect an interruption, and for example, a high gastric ratio volume. A limited number of studies notice it, but it is important because you can have other outcomes of the studies. It makes it difficult to compare them. Several studies report the duration of INE in different ways. Think about for example, some reported in percentage, some in hours, and others in days. So the conclusion and recommendations. Now, we conclude that more than 70% of the patients achieve their nutritional goals, but there is still another group who doesn't get their nutritional goal, the targets. Now, this group has a high risk of malnutrition, so it may be good to look at good, as why we chose for some protocols. For example, the common reason for an INE was CT scan. It's a very practical interruption, but is it necessary? And how much is the risk of aspiration when they get a CT scan? CT scan results most of the time in a shorter interruption. An intubation and extubation, on the other hand, for example, can go up to 8 hours. So that is 33% of your nutritional targets. Patients are kept so because the risk of aspiration, again, you may be able to deflate the stomach before you start with the intubation. So a patient will have the minimum amount of INEs. There are also patients who get more INEs a day. So I think there's a lot of work to do. We may have to think about the protocols and evaluate whether the interruptions are really necessary and keep them to a limit, or try to compensate them in a certain way. For example, you can give an extra portion of enteral nutrition later in the day, so your target intake can be reached. So this was my presentation. Thank you for listening. Now you can ask me some questions. I have the references over.
That was excellent, Monica. Besides the calorie intake, were you looking at even micronutrients, which are also very important in especially critical care patients? So one is a calorie intake, which you nicely demonstrated in your study, but what about micronutrients? Were you looking at that part as well?
Thanks for your question. We only look at the calories, not at the micronutrients. I agree with you that that's also important. Maybe later in another study we can research too about that. Enteral nutrition consists also micronutrients, so maybe you can it's difficult to explain, but enteral nutrition, if you get enough for a day, you get also enough micronutrients, because the enteral nutrition consists all of your nutrients a day. So maybe you can we can also make a conclusion out of this information.
Well, thank you very much, Monica, for the presentation and the study. I just have one question, and then we'll invite the other panel members as well to comment. One of the findings that you said is that at the first few days, this is the period where the most of the interruptions happen. Do you have an explanation why, especially in the first few days? Because all of the causes like CT scan or other things, they can happen any day, not usually in the first few days. Do you have an explanation for this, or why especially the first few days?
Yeah, I see Dr. Powell's laughing.
Yeah,
He has to answer.
Maybe I can help. Just to put this data in a bit of a more detailed context. Our hospital has a, it's called a supra-regional function for neurosurgery, and is also a level 1 trauma center. And in our ICU, we have a high proportion of neurosurgical patients who normally in the acute and subacute phase get a lot of CT scans, and those happen basically in the first 3-4 days. So that's one explanation. And secondly, also our surgery rate, especially for trauma surgery, of course, but also for neurosurgery, is really high. So that can be an explanation for the relatively high amount of CT scans in the first few days.
All right, yeah, thanks, Jack. That's a very interesting study, actually. I can see also Dharmanand is raising his hand, or do you have a comment there?
I wanted to say the same as Dr. Pauls, but we followed the patient 7 days, but you can imagine if a patient who stays longer on the ICU, he becomes deteriorating or he gets sicker, then we also have to do a lot of scans then. So we didn't account for that, but the follow-up was limited in these patients.
Yeah, we just to comment on that specific topic, we there's one or two studies, one from Lithuania and one from Russia, if I'm correct. They followed every patient for 7 days, and of course, patients who are longer in the ICU can also get problems. Just as a spoiler, we have collected data on patients that were longer in the ICU, but it wasn't part of this study, but for part of a second study, and we're analyzing that data at the moment. So those results will follow.
The study was from Lithuania.
Yeah, Lithuania. Yeah.
Yeah.
Is Dr. Misha with us, Jack, or?
Yeah, I saw someone who.
Yes, I just finished the OR.
Welcome, Misha.
Be a little bit later.
Misha, I don't know if you have followed a part of the presentation. Do you have any questions for Monica?
Yeah, I only followed the last bit.
Let's state it this way. I earlier introduced you as the surgical nutritional guru in the Netherlands, which actually is your subtitle, if I'm correct. What part of nutrition in general do you think needs to be optimized in the perioperative care or peri-ICU care for patients? Can you enlighten us on this topic?
I think the things have changed over the past years. So first we were very focused on malnutrition and sometimes even overfed the patients, and start of nutrition, especially enteral nutrition, was very important. And now, by the insights of Greet van den Bergen from Belgium, you see that a more restrictive nutritional policy may be beneficial for some critically ill patients. We focus on the surgery, and especially after major abdominal surgery, even esophageal surgery, and Thijs is going to elaborate on that in a little bit. But we see that early start of oral nutrition is almost feasible in all patients, and this also leads to nice side effects, that patients mobilize faster and stuff like that. So I think we need to have a tailored strategy for each patient. For the very sick patients, the critically ill patients, you may have a restrictive feeding regimen. For surgical patients, you can start nutrition right away, but you don't have to overfeed the patient. And generally, I think you have to start enteral nutrition it's better than parental nutrition. And I agreed with the slides that I saw about the interruptions of nutrition. You have to reduce that as much as possible. In normal elective patients, I would say make the fasting or nil by mouth period as short as possible.
Thank
Does
you very
that
much.
answer a little bit of your question, or?
Yeah, it's a very impactful and broad question. So yeah, but thank you, Misha. Perhaps this is a nice bridge to our second presentation. Don't you agree, Mohammed?
Yes, agreed. Yeah.
As a second speaker of this TUGS Lounge session, I would like to introduce Dr. Thijs Jansen, also from the Catharina Hospital in Eindhoven, the Netherlands. And I have been told that you're going to enlighten us on the perioperative optimization in patients who will get esophageal surgery. And you're a PhD student at the same department as Dr. Luijer. Thijs, the digital floor is yours.
Thank you, Dr. Pauwels. Is my presentation sharing now?
Yeah.
Okay, perfect. So yeah, as you said, I'm Thijs Jansen. I'm a PhD candidate at the Catharina Hospital. I'll be speaking about peri and preoperative optimization of patients undergoing esophagectomy. The cornerstone of treating resectable esophageal cancer is an esophagectomy with or without neoadjuvant therapy. Survival rates have improved after introduction of chemoradiotherapy, but esophagectomy is still associated with a lot of morbidity. There's been a few improvements over recent years. The introduction of minimally invasive surgery. However, there is a substantial learning curve that has to be adjusted for, and introduction of enhanced recovery after surgery. And as you earlier mentioned, the direct oral feeding that we researched in the nutrient trials and the prospective cohort study afterwards. And latest optimization has been prehabilitation in the preoperative phase. So I'll be discussing the nutrient trials and prehabilitation in more detail. And the reason for this, for all the improvements, is that all both of the morbidity is not only a problem for short-term outcomes and quality of life, but we've also seen that, for example, occurrence of anastomotic leakage, but also complications in general and cardiopulmonary complications may reduce long-term survival. So it's important to reduce complications as much as possible. Enhanced recovery after surgery, I think everyone knows about this, and it's very similar in most types of surgery, abdominal surgery. There's a few key elements. Most elements combined lead to the effect of ERAS, but there are a few key elements, such as early enteral nutrition, as Misha said, early mobilization, standardized analgesics, and minimally invasive surgery. And if you look at early enteral nutrition, there are indications in other types of major abdominal surgery that early oral feeding is better than tube feeding because patients mobilize faster and there's less home care that you need to account for, so patients recover faster. The only problem is that in most institutions, oral feeding is delayed and patients are kept nil by mouth out of fear for anastomotic leakage or aspiration pneumonia. That is why we did the nutrient trial. This was a single-arm multi-center pilot study conducted in the Netherlands. and it was found that direct oral feeding from post-operative day 1, it was a liquid oral diet, was safe and feasible. And if you look at functional recovery, I'll show the details on that later, that patients directly starting with oral feeding recovered it in 10 days, and the retrospective cohort with tube feeding recovered in 12 days. So the functional recovery criteria, we use them in all studies. They are basically the discharge criteria, but sometimes patients have to stay longer in the hospital because home care is not set up, or the patients are just not yet ready to go home. Secondary outcomes are surgical complications and length of hospital and ICU stay. Next was the Nutrient 2 trial. After the pilot study, we performed a multi-center randomized controlled trial. This was international with the Karolinska Institute, and only patients with undergoing a minimally invasive esophagectomy with intrathoracic anastomosis or the Ivar-Lewis esophagectomy were eligible for inclusion. Exclusion criteria were inability to tolerate oral intake, a low performance status, and a high preoperative weight loss percentage. 222 patients were eligible. After exclusion, 184 were randomized, and during surgery there may be some factors to exclude patients as well, which is why 132 were included in the final analysis. We had 65 patients receiving direct oral feeding, and 67 received standard of care, which was nail by mouth for 5 days and tube feeding, and then starting on day 6 with oral nutrition. On the right side, you can see the feeding regimen. So on post-operative day 1, patients start with a liquid oral intake. The evening after surgery, it's only clear fluids, and the next day they start with oral feeding. On day 5, the dietitian calculates caloric intake, and if patients don't reach at least 50% of what's calculated, then they receive tube feeding as well. Or in case of a complication, patients also that requires tube feeding patients receive tube feeding. We've consistently found that approximately 70% of all patients can adhere to the nutritional protocol, and 30% may deviate because of a complication or passage problems without any functional complaints. So the outcome of the Nutrient 2 trial were that functional recovery, as I mentioned earlier, was similar. Length of hospital stay and readmission rate was similar, and postoperative complication rate was similar, with the exception of Gillis leakage, which was significantly lower in the direct oral feeding group. Although baseline characteristics were similar, there was some heterogeneity in certain aspects, such as in eras and in surgical factors, which may have contributed to differences in outcomes. That's why we performed a prospective cohort study. It was the same design as the Nutrient 2 trial, but we've added more patients prospectively, and a combined total of 196 patients were included in this trial. 85 received direct oral feeding, of which 47 were from the Nutrient 2 trial in our hospital, and 111 received standard of care, which was nail by mouth for 5 days. Baseline characteristics were similar, but the overall characteristics were that age was approximately 66 years. Most patients had ASA score 2. Comorbidities were present in the majority of patients, and in terms of neoadjuvant treatment, most patients received chemoradiotherapy. And now to the outcomes. If you look at functional recovery, patients were recovered at a median of 2 days sooner than the standard of care group. as well as length of hospital stay. And if we look at the per protocol analysis, so all patients, the 70% that could adhere to the protocol, 6 days was functional recovery versus 7 days in the control group, and length of hospital stay was 7 days versus 8 days. So both were significantly shorter compared to the control group. Other outcomes were overall complication rate, which was also significantly lower, which may be attributed to the fact that Achilles leakage was absent in our direct oral feeding group. And more importantly, if you look at pneumonia and anastomotic leakage rate, these were similar between both groups. So again, it would be, it's safe to say that direct oral feeding is safe and feasible in esophageal cancer patients. Now I'll be discussing prehabilitation because, as you can see, morbidity is still high, 60% for overall complications, and cardiopulmonary complication rate is also still approximately 50%. The aim of prehabilitation is to optimize patients preoperatively to better prepare them for surgery and the surgical stress response, and thereby reduce postoperative morbidity. We have introduced the PREPARE program. This was first implemented in the Imperial College in London, which we visited and implemented their PREPARE program. It's a home-based program. It's personalized, so it's tailored to the patient and supervised from the hospital. It's a multimodal prehabilitation program, which means that that is not one aspect you're looking at. You're also looking at nutritional status, functional capacity, mental well-being, and behavioral change, such as smoking cessation and lessening alcohol usage. And the aim is to optimize this already fragile patient group that's at risk for malnutrition and skeletal muscle loss, which may lead to sarcopenia. We've implemented the full program since August 2018. It's a quality improvement of the entire patient care pathway. So it wasn't a trial, it was just implemented because there was enough evidence that it may benefit patients with esophageal cancer, and only patients with resectable esophageal cancer, so patients that would undergo a surgery, were included in the program. And during the follow-up, patients, it was found during diagnostics that patients had a metastases, they would enter palliative care. It's a large team consisting of paramedics, as well as other specialists from the intensive care and anesthesiology. As I said, it encompasses the whole patient care pathway, which is approximately 20 weeks in total. And there's a few measurements. 3 are preoperatively, 2 weeks after staging, 9 weeks after staging, and in between those 2 measurements, patients receive neoadjuvant therapy. And then there's one measurement 1 week prior to surgery, and a measurement 6 weeks after surgery, after discharge. Now, the aim of prehabilitation, this is a study by Minella, which is one of the few prehabilitation studies in esophageal cancer surgery, and it was shown that functional capacity, they expressed it in the 6-minute walking distance, so the amount of meters patients could walk in 6 minutes, and they showed that prehabilitation leads to a significantly better functional capacity compared to control patients that did not receive any prehabilitation. Their outcomes did not differ. There was a clinical reduction of complications, but it was not significant, which may be attributed to the small patient sample size. So what do we measure? As I said, the 4 measurements, a lot of specialists involved, such as the nurse specialist. She takes the distress thermometer and discusses the social network. We take quality of life measurements. The dietitian screens for malnutrition with the PG-SGA list. I'll discuss that in detail a bit later. And the physiotherapist measures some physical goals, which I'll discuss later. So the PG-SGA is a screening tool for malnutrition. There's a lot of items you can score, but in the end, there are 3 stages: well-nourished patients, suspected malnutrition, and severely malnourished. And these provide guidelines for dietitians to either start tube feeding preoperatively or nutritional drinks or stuff like that. And this PHS score is taken to is taken as well. So physical exercises, patients receive a schedule for each week, which is shown here. It's just an example, but the goal is to have patients do all these exercises each day, and this will be discussed each week with the physiotherapist. Patients are trained to score the exercise by amount of exertion. We use the Borg scale. There's also a modified Borg scale, but it shows you how tough the exercise was for that week or that day. We also do respiratory exercise. It's a threshold inspiratory muscle training, which is set for patients, and the aim is to breathe through the tube for 20 minutes each time. At first it won't be possible, but it's the follow-up training. Then we have the STEEP-REM test. It's not the usual CPAT test, where you also do the gas analysis. It's a short time maximal exercise test, whereby the workload is incrementally higher, and it gives you an estimation of the VO2 max. We use the VO2 max as the functional capacity. So the study by Manella used the 6-minute walking distance. We use the VO2 max, and it monitors the endurance so that you can adjust training for each patient. Then we measure the inspiratory muscle strength. We use a mean inspiratory pressure device, and this monitors the strength of the inspiratory muscles, which will then be used to adjust the threshold training. Some few smaller tests: the time chair stand test, which gives you an indication of the lower extremity muscle strength, and we use the grip strength as an indication of overall strength and the health of patients. The perioperative phase, it's similar as the Nugent trials. Patients are actively mobilized the evening after surgery to sit in the chair, which is intensified each day, and the goal is to walk at least 1,000 meters on postoperative day 4, and they also use breathing exercises and the Mediflow, which is shown on the right side, to increase to improve inspiratory muscle strength. Nutritional aspects have also changed. It was not necessarily part of the PREPARE program, but the pureed food shown on the left, which was used in the Newton 2 trial, was changed to more frequent and small meals, shown on the right. And by the looks of it, these on the right are more, they look more tasteful than the food on the left. So it also motivates patients to eat, even if they don't have if they don't have the feeling they have to eat. This is just an example. I'll not discuss this more because, as I said earlier, it's a liquid oil diet, and each patient has their own choice for to reach the nutritional goals. But the aim is to increase liquid intake to day 6, when they can use a limited amount of liquid intake. And on day 15, they start with a solid intake. And as I said, and on day 5, caloric intake is measured. If they don't reach 50%, then tube feeding or additional tube feeding is initiated. So it's not necessarily 100% tube feeding, but it may only be 500 cc of tube feeding. Then the outcomes. To minimize the confounding effect of ERAS and neoadjuvant treatment, because patients without neoadjuvant treatment cannot be rehabilitated because they directly undergo surgery. We've excluded all patients with delayed oral feeding, so only patients with direct oral feeding were included, and patients that underwent a direct resection were excluded, as well as patients with active surveillance. In some patients, you see that chemoradiotherapy leads to a full remission of the tumor, but in the follow-up, it may return, and it will be delayed. The time between surgery and chemoradiotherapy will be delayed. So we've only looked at those patients. We had 52 patients with the rehabilitation program and 43 controls, of which most were from the Newton 2 trial that received direct oral feeding. Baseline characteristics were similar. There were a few more comorbidities in the PREPARE group, but it was not significant. If you look at the outcomes, functional recovery was 1 day shorter, but it was not significant. On the other hand, length of hospital stay was 1 day shorter. ICU readmission rate was significantly lower, and complication rate was lower, but not significantly. But it was clinically relevant because it's 50%, 60%, as well as cardiopulmonary complication rate. If you look at the more functional outcomes of the PREPARE program, we've only looked at the PREPARE patients because the controls did not receive undergo the steep RAM test. If you look at the VO2 max, this is baseline P1. P2 is after neoadjuvant therapy. You see that it's significantly lower and then returns back to baseline. And the expectation is that patients in the control group would not go back to baseline, but stay on this level or maybe even go lower after neoadjuvant therapy. For the mean inspiratory pressure, so the inspiratory muscle strength, we see that overall, over the whole preoperative phase, it improves significantly with the threshold training. Postoperatively, we see that the VO2 max and the mean inspiratory pressure both decline significantly, which is expected because surgery and the admission in the hospital leads to a lower functional capacity. More importantly, if you look at table 3, there's a relationship between a lower VO2 max functional capacity and the occurrence of cardiopulmonary complications. So it's approximately 5 points lower in the patients with cardiopulmonary complication, as well as in the group of patients with a 30-day overall complication. So especially in these groups, which will also be one of the future perspectives, is how can you improve patients that already have a lower VO2 max at baseline and are therefore at risk for postoperative morbidity. We're looking at implementation of e-health, using activity trackers to better adjust the exercises and also give insight in the compliance to prepare, because now patients fill in the exercise schedule on paper and you don't have any means to really check compliance, which an activity tracker may help you with. And on the other hand, we want to expand it to other types of cancer surgery. Finally, we're currently doing the Beat Me trial. So next to training, there may also be supplements that can improve VO2 max. We use beetroot juice from the manufacturer James White Rings, which is nitrate rich. And it's said that nitrate is performance boosting. And James White Rings provides both the nitrate rich drink and a placebo shot, which is exactly the same as this one, but they removed the nitrate, and we're currently doing an RCT on that. And there's a few key elements that nitrate can improve VO2 max by, but in general, it's said that it can improve the time to exhaustion and improve oxygen efficiency in the cells as well. Yeah, that was the end of my presentation.
Thank you very much, Taj, for such a nice presentation. And I think it's very evident nowadays that nutrition rehabilitation is very important in surgery, especially in cancer patients. So, Dr. Misha, do you have any comments or about this sort of presentation?
Well, it looks evident, but the first time when I presented this, most esophageal surgeons thought I was a criminal to even suggest giving oral intake to these patients. So, and I think we did a survey in Europe that most patients are fasted for the first days. I think only Ed, who is also in the call, is one of the guys who is going to, who is also feeding them directly. So it looks evident, and there is a lot of evidence which we produced also, but many of these patients are still fasted.
Yeah, I think it depends also on the surgeon's experience. Or Prof. Vish, do you have any comments about this for like giving them oral for esophageal cancer patients, feeding them or giving them early oral liquids?
Yeah, thank you. Hi, Misha. It's nearly 3 years.
Hi. Nice to see you again.
Yeah, wonderful. And I'm sure we are involved in many virtual projects and some projects. So, no, I think going back to Misha's comment, I entirely take his, first part of his statement. When somebody after a foregut anastomosis feeds them, if it enters into a mediastinum, it is much more life-threatening than a peritonitis. But based on that, historically, last 50, 70 years, foregut surgeons never used to go in a fast pace to feed orally. And certainly with the rehabilitation, minimal access surgery, I think a lot of traditional surgeons are embracing the idea of early oral feeding. Myself is probably I've moved from 4 to 5 days a little bit early. That's all I would say, but not day one, as Misha, as this trial proves. But I'm sure we are moving in that direction. But again, going back to the normal human salivary secretion, we all swallow our own saliva. Saliva itself contains nearly a liter of saliva we swallow. But in this trial, clearly they've given the oral liquid calorie containing fluid. It's not solid food. So I don't see why we can't, going back to, 500 cc is half of our normal saliva. We don't ask esophageal patients, we don't ask them to spit. We ask, that's nevertheless. So I think, we are moving in that direction. It's fantastic for Misha and his team to prove this in a evidence-based manner. And I congratulate them for that.
Thank you, Pravesh. I think one of the difficulties here, I'm not sure, Jack, what do you think about the difficulty of implementing this PREPARE system is the prehabilitation system is also, it requires a lot of resources, and because it's like a multidisciplinary team from pre-surgery, it requires like a nurse specialist. So I'm not sure how much can it be implemented, or how much is it implemented in the UK or Netherlands around different hospitals.
Yeah, that's a good question. But as Misha already stated, when you're implementing something, possibly revolutionary, you're being looked down on, basically. I remember a story of Dr. Smulders, who's actually a colleague of Misha, introducing an ERAS protocol for bariatric surgical patients. At the time, it was new, scary, frightening, and nowadays it's standard practice in bariatric surgery, at least in the majority of the world. Same goes for the introduction of the sleeve gastrectomy back in the days. No one thought of it, that it would change in a standalone procedure. So I think the key factor is look for people who you need from different specialties, who have the same vision as you, and form some sort of collaboration within your hospital. And I think that is the key role of success, to get something implemented.
Yeah.
And yeah, not only for surgery, but for basically everything.
If I may add, the current PREPARE program, there's a few hospitals in the Netherlands that have been trained in PREPARE. We call it clinical immersions. So they visit our hospital, they follow the whole pathway, and then implement PREPARE or some parts of it, make it their own. So in terms of implementation, it's actually going pretty well in the Netherlands.
Yeah, but to comment on that, Thijs, you've talked about exercise, and especially in these rehabilitation programs, I can imagine a lot of oncological patients, not only gastrointestinal cancer, but also lung cancer and so on, are not that trainable. And
yeah, it's not completely true, Jack. That's not completely true. So what you see is that you need to adapt your program, and we always give the example that they need to undergo or need to run a marathon. But what you can see is that you can improve them from conditions named, we always rank it 0 to 10. And if they are a 7, you need to go to an 8. And if you are a 6, you go to a 7. But maybe for you, a 7 is different from the condition of an 80-year-old who is a 7. But still, it's the delta improvement which is beneficial. So, so you don't. Of course, we all want marathon runners who are in a good shape and not overweight and stuff like that. But it's not possible. But I think the data from Thijs shows that that the improvement which is needed, that will be the beneficial part.
Yeah, I do agree. But my real question was, you were a bit too fast, Misha. Is you showed us exercises, but my question and my interest is, how do you select these exercises? What because you need to form some sort of program, and how do you do it? Because that was my real exercise. Of course, I know we're not looking for marathon runners. That would make our life very easy, but for our patients, basically.
Thijs, do you want to comment or shall I comment?
I didn't hear a lot because the connection was bad.
Oh,
We
oh,
say, I
oh.
mean, we have a fixed program based on yeah, exercises that were selected by physiotherapists, and these are all cardiopulmonary exercises like you do in a gym, and which are fairly easy to do without any additional attributes. So you can do it at home. You can walk the stairs and walk around and stuff like that. So these are exercises that boost your cardiopulmonary fitness, but you can do it without much resources. Does that answer your question?
Yeah, it does.
Yeah. All right. Thank you very much, Thijs. I think, Jack, anyone has any other comments from the audience or from the panel members? I think we're past our meeting time, Jack.
Yeah, I think so too.
Well, I think then we'll conclude the session. That's okay, Jack. I think very nice presentations. Thanks, Monica and Thijs, and thanks for the panel members, Dr. Misha, Provish, and Panamanand. Jack, thank you very much.
Yeah, you're welcome. It's always a pleasure. Thanks for our panel members and our presenters. And let's not forget, next month we have a new TUGS Lounge session with a new set of moderators, presenters, and panel members. So I would like to invite everyone to join us in a month.
First Thursday of every month. Thank you very much, and good night.
Good night.
Thank you.
Thanks. Bye-bye.